The following podcast is part of a certified educational activity titled Raising the BCMA Standard in Multiple Myeloma, Strategies for Enhanced Care with Potent CAR-T and Bispecific Options. Access the entire activity and complete the post-test at peerview.com/MGG860. Downloadable slides and practice aids are also available.
Good morning, and welcome to this symposium, Raising the BCMA Standard in Multiple Myeloma. I'm Nikhil Munshi from Dana-Farber Cancer Institute, and it's my pleasure to be here with my co-panelist, Dr. Karina Patel from MD Anderson, Dr. Mohammad Moti from Sorbonne University, and Dr. Hans Lee from MD Anderson Cancer Center. It's interesting that the title is Raising the BCMA Standard. Last year, we had a similar symposium on BCMA as a target in multiple myeloma. In 1 year, we are beginning to raise the standard. So that tells you the progress in this disease. Why this symposium? It's because of the great advances we have. If you can see these curves from 1970s to 2000, we have significant improvement in outcomes in these patients. However, one of the challenges has been the attrition. If you look at the patient population, only quarter of the patients will end up receiving more than 4 lines of treatment. And I think that's a major issue, so that we need new drugs to be started sooner. There's a very nice presentation in this ASH which looks at the real-world data. And it tells us that if you have patients with triple-class exposed or triple-class refractory patient, they do not remain on the treatment for very long as they're beginning to become resistant. So we need good treatments, and we need good treatment soon. Now, what has happened in this field? I mean, if you look at our traditional drugs, which are very good drugs, we all use it as a standard of care, pomalidomide, lenalidomide, bortezomib, their approval has been based on 30% response rate, and they're still one of our best drugs in combination. What has changed in the last 2 years is that if you look at the 5 most recent drugs approved in this disease, they all have response rates 60 to 98%. Very different landscape now in how we use it, and that's why a symposium like this is so necessary. We have BCMA targeting drugs approved since 2020, belantamab, which in US currently is withdrawn because of the DREAMM-3 data, but there are very encouraging combination results there. We have 2 CAR-T cells, ide-cel and cilta-cel, and then we have 2 bispecific teclistamab and amivantamab. And more recently, talquetamab targeting GPRC5D is also approved, and you will hear about the advances that uses of this agent. So the goal for us today is to improve our knowledge about mechanism of actions and the clinical evidence for their incorporation in treatment, both CAR-T cells and bispecific. Understand how do we integrate this treatment in our practice, at what stage, what line of treatment, and then learn about the toxicities, learn about their deliveries, and other nuances of taking care of these patients in our practice on an ongoing basis. Now, this symposium is also sponsored by HealthTree Foundation for Multiple Myeloma. HealthTree provides lifetime personalized support and education to patients. It provides meaningful patient-to-patient connections and a powerful patient data portal which transforms patients into active contributors to research. Very important component of what we do, having a real-life evidence like this. There have been 76 surveys, 65,000 study participants, 78 investigators involved, very broad, very comprehensive analysis being done. So with that background, I'll move on to discussing the first part of this symposium, which is on track for better outcome with BCMA CAR-T cells and the clinical experience till date. So we'll go with the case first. So this is a 76-year-old gentleman, relapsed refractory myeloma, performance status 1, has 4 lines of therapy with RVD induction, transplant, with RAV maintenance for 2.5 years. Patient received Dara Pomdex, then on a progression received carfilzomib dex and subsequently received carfilzomib cytoxan dex. Now patient is progressing. creatinine is 1.8. And so the question from my colleagues here is, and this is a real-life scenario. We see these patients very often. Half of the patients in myeloma are above age of 70 at diagnosis, and then you follow. So we are dealing with half the patients who are going to be above age 71. This gentleman is 75. So to my panelists, the question is, does the age matter?
Yeah. I think we've had this conversation a few times, but no, I think, at least in the U.S., we don't say that any age cuts you off from any type of therapy for myeloma. And we know that different people of different ages are different functional capabilities. So there are patients who are younger that might have multiple comorbidities that I might not take versus an older patient who, is doing great, not very many comorbidities. Our oldest patient's 90 that we've taken to CAR T. So I think, we have to make sure they're going to do well. And we might need extra people to help us to get them through. But to me, age doesn't matter.
I think age is a matter of mind, and actually when it's about comorbidities, it's about general status. And when a patient or someone is 75 or 76, actually, in theory, you still have another 9 or 10 years of life expectancy. So it is worth to envision any effective treatments.
So Dr. Lee, does creatinine of 1.8 bother you?
Yeah, so the creatinine is a consideration potentially as part of lymphodepletion when fludarabine is used prior to CAR T, but there is data supporting the use of fludarabine and CAR T in patients with renal dysfunction. So that in itself wouldn't necessarily preclude, but one must consider the dosage of fludarabine depending on the creatinine clearance. And so that is a consideration, but not a deal breaker.
Thank you. So I think that's a very important point, that unlike transplant, where we are more careful with age, performance status in a strict sense, also renal function in a more, sometimes liberal, but also quite keeping in mind. For CAR T treatments, we do not have those many restrictions. We all probably have patients above age of 80 or near who have had CAR T cells successfully and safely. So I think we have a much broader patient population. Similar to add, the cardiac functions are not as strictly followed. We don't always end up doing ejection fraction, etc., depending upon patient's performance status. So we have a broader latitude to select patients based on their other cardiopulmonary morbidities and other comorbidities. So if we look at what drives this result, there are two approved CAR T cell products. One, ide-cel, which the 41BB as the molecule and CD3 zeta, and you can see on the left side. And then cilta-cel has a unique dual binding domains for CAR T cells. Both of the products are now commercially available, and we are all experienced in using them. Now, the guidelines suggest, there are many guidelines, but they're all partly driven by the FDA approval process. So FDA approval is for CAR T cells at the present time, and we're hoping it'll change, as we will discuss soon. But at the present time, patients should have 4 prior lines of therapy, and it must include proteasome inhibitor, immunomodulator, and anti-CD38 antibody. Both cilta-cel, supported by Cartitude, and ide-cel, supported by Karma, have been extensively utilized, and you will hear more about the bispecific later on in this session. Now, Karma 1 was the approval for ide-cel. It showed that there's a target dose of 450 million cells, which we try to get to. The overall response rate was 80%, with close to 40% patients getting CR. This treatment works incredibly fast. The median time here is called 1 month for response, but we have all had patients who would have responded within less than a week. Literally in front of your eyes, they respond. So very fast-acting treatment. And with a median follow-up of 13.3 months, the PFS has been around 8.8 months, except patients achieving CR, 12 months. The second CAR T cell is based on Cartitude-1 data for cilta-cel. The results are incredible, 97.9 and 98% response rate, 82% patient achieving complete remission. And the most recent update shows that the PFS is 35 months, duration of response is 34 months, so almost 3 years of PFS. And I must remind you that these are the patients who have had median of 6 lines of treatment. So very advanced disease. Any other alternate treatment in this patient group would have a PFS of between 3 and 4 months. Response rate at the best would be 20% or thereabouts. So incredibly effective treatment. And if you look at overall survival, median has not been reached yet, but at 3 years, 63% patients are alive and event-free. So incredibly effective treatment for both of them. One more point, why do we all say age doesn't matter? Because we are all getting old too. But it's because I think the results are very similar if you look at young patients or patients above 70. 70 is not old. So you can see the responses are similar between 65 and 70. And very importantly, if you look at the toxicity, patients above 70 do not have excessively higher toxicity. Their tolerance remains relatively similar. So I think we have to keep that in mind as we select patients for our treatments. What is more important is not what we do in the study, because in study we have a very prescribed criteria for entering patients. They're better patients. However, the real-world data is most important to look at, and we have now real-world data for both the products. So if you look at ide-cel, in the real world, 75% of the patients who got ide-cel would not have qualified for the study itself. So they're sicker or more having comorbidities. Even then, you could see the outcome is outstanding. And if you see for cilta-cel, exactly similar scenario, majority of the patients would not have qualified for CARTITUDE-1 in the real world, 143 patient data. And you can see that with the median follow-up short, because this is available only for a year, PFS is 67% at 12 months and OS 80% at 12 months. So even in real world, where we put much sicker patient, the outcomes are very, very encouraging for this patient population. Now, let's look at the case a little further. So there are 2 more data points for this patient. One is that the bone marrow before going on CAR T-cell for this patient had 90% involvement, so high disease burden, and patient had T414 and 1Q gain. And the newer definition of high risk that you will hear in the near future, the both combined makes it a true high-risk patient population. So the question to my panelists is that this high disease burden, do you think one needs to worry about it in regards to toxicity, CRS, ICANS, or others? So I would love to hear your views.
No, I think this is great. In the trials, patients are relapsing and that's how they get on. In the real world, the logistics, especially for our sicker patients, make it much harder. I think getting them to collection is really important. So yes, if I had a slot for this patient, I can get them in. I want to get the cells done so that we can start making them, because it can take 4 to 8 weeks. But during the bridging, my goal is to knock that 90% down as much as possible, because we do know that there's much higher CRS and ICANS when you have a lot of myeloma going in. And the responses are much better when you have less myeloma, longer PFS, et cetera. So bridging really, really matters.
I think based on the experience with lymphoma and ALL, we thought that the incidence of CRS and ICANS would be higher with high tumor burden. I think in myeloma, the current experience suggests that there are some good news, that the incidence could be relatively high, but the severity is very mild, moderate, grade 1 and 2. So I wouldn't be worried about it.
I think this case points to an important point, that it's really important to have a bridging regimen that you can use. And I think speaks, and Karina will talk about this earlier, about using CAR T in earlier lines of therapy, because having that bridging regimen that's available to try to reduce the patient is important. And even potentially in this particular patient, the patient received cyclophosphamide just before this next line of therapy. Again, perhaps trying to avoid or mitigate the exposure to alkylator agents prior to T-cell collection may be another important aspect of this case.
So then the second question is, and it's a little bit more broader question, is the patient is a high-risk myeloma. So there are 2 aspects to it. One is, does it impact the outcome of the patient? And number 2, does that make patient a candidate that we should be thinking about this type of intervention at a different time point? So first question, do we think that having a high-risk features impacts the outcome of these patients?
Yeah, so we know our novel immunotherapies really work well for our patients with high risk, but they still don't make them standard risk, right? Every hazard ratio forest plot shows it's usually our high risk patients, cytogenetics, even extramedullary disease, pentarefractory patients that tend to have that lower PFS. So the earlier I can take this patient, the better. So when we talk about my talk, yes, like this patient is going to be much harder to get through collection, bridging, and to actual infusion of cells at this point than if they had less myeloma and maybe not so much high-risk disease. Because even during bridging, as Vahan said, what are we going to give them when they've been exposed to all of this to actually cytoreduce to get them to, even the infusion?
CAR T cells are a form of cellular immune therapy, and this is an agnostic form of treatment. So one would envision that it should work very well in the high risk. However, it's a sort of a gray zone for the time being. Work in progress, I would say, but definitely it's a very good option.
So definitely, I would modify the question a little bit. So these high-risk patients would end up with more chances of having extramedullary disease, because that's the nature of the disease. And there's a lot of discussion about escape from this therapy with EMD. So could you highlight on the role of EMD in treating these patients and how we need to be probably doing it anyway, but emphasizing the follow-ups in certain way?
Yeah, so that's a great point. And EMD has been historically a very, very difficult patient population to treat with our therapies that we have currently available. It's historically been difficult to get responses and to have durable responses as well. And so even with CAR T and bispecifics, it's still been a challenge to have durability of responses. EMD is a poor prognostic marker. And so I think this is where we need novel strategies, maybe consolidate patients who still have residual EMD with radiation or other novel immunotherapies. And I think that's still an unmet need that I think is an area that we will still focus on in the future.
So if you look at then toxicity issues, they're standard toxicity. Both ide-cel and cilta-cel, they almost uniformly, 90% or so, has CRS. Now, for lower grade, I think well managed, I think over the last 5-7 years since we have been all doing it, we know how to manage these patients. Similarly, the neurotoxicity around 20% or less, usually low grade, very few patients are grade 3. And the toxicity management also for that is very standardized. And then cytopenia are something that I would be more concerned with because that can last and that can cause infectious problem. Similarly, delayed neurotoxicity, as Dr. Patel said, we control the disease burden, we can mitigate some of those issues as well. Now, two of the toxicity CRS, and I'm sure you have heard a lot about it, so I wouldn't go into great details. Starts with fever generally. Then occasional patients could have respiratory issues, hypoxia, and or blood pressure, cardiac issue, hypertension or tachycardia. And the supporting care plus tocilizumab covers it very well. Rarely we require steroid in this patient population. And same way neurotoxicity starts with headache, but then confusion, delirium could be a little bit more advanced phase, exceedingly rare. You could see encephalopathy and related issues. Again, tocilizumab followed by anti-seizure medicine and also steroids are standard of care. So I think there is a very good management algorithm for this patient population. However, one question I would like for the panel to answer, because this has been very much at the forefront of recent discussion in CAR T cell, not just in myeloma, but also in lymphoma. There was this recent announcement by FDA about having second malignancy, T-cell malignancies, with all various CAR T-cell products. So I think I would like to get view and emphasis on the importance of treatment versus infrequency of this kind of side effects. So I think, would you highlight on that?
Yeah, no, I think that's a very important topic. We know that this is a potential, and that's why we follow our patients for 15 years when they've gotten CAR T, both on trials and standard of care, to make sure that we're not seeing this. And I think it's about 19 patients out of 7,500. And we look at SEER data for at least lymphoma, you actually see that a higher risk of T-cell lymphomas and leukemias as secondary cancer. So I think it's really important to put this in context. Yes, it's important for us to look at this, make sure we're not seeing a big signal, and if we do, what do we do to change that? But really, the risk of myeloma, and especially these patients, is more likely going to cause lots of problems. And we have such amazing responses that, it's important to talk about it, to look at it. But clinically, we know that they have that same risk even without CAR T. So I think it'll be important to see what the data shows, but I'm not too worried about it.
I believe we all agree that stringent pharmacovigilance for any new therapy is crucial. And I think our regulatory bodies should be praised and commended for doing this. Having said this, we need to be pragmatic. And this story reminds me of ASH 2015, when there was this alert about secondary primary malignancies with lenalidomide, which is a true fact. But at the end of the day, I believe in myeloma, and now after hundreds, if not thousands of patients being treatment, I believe these patients are dying from their disease. And we need to be aware of the side effects. Obviously, the investigations are ongoing, and we'll know better about it soon, I hope. But at this time, I don't believe there is a reason for big alert, red flag, etc. Work in progress.
So, Dr. Lee, do you do anything different with this new knowledge?
Yeah, I agree completely with my colleagues. I think this is important to track and study, but at the end of the day, does it significantly alter the risk-benefit ratio of this therapy? And I would say no. And I think, as people have mentioned, the risk of myeloma is very, very high. The risk of having bad complications and dying from myeloma is very, very high. So at this point, with the data available, the risk-benefit ratio has not been altered in my mind.
Perfect. So if I sort of repeat myself, because this is a very critically important point that the physicians ask, the doctors ask, and everybody else, is that both lymphoma and myeloma patients are older. They have a higher risk of second malignancy, period, whether it's lenalidomide, post-lenalidomide, or post any other treatment. These treatments are so incredibly effective at a stage where they don't have many options, and even in an earlier stage. And the frequency of what is currently observed, T-cell malignancy and or other, is so small that in none of you heard our panel, but also our colleagues out, not on the panel, have the same opinion. This hasn't affected anything we do even a bit. And I think that's the right decision. That's one part. The second part for all of us to remember that we have to be vigilant. As Professor Moti said, pharmacovigilance is important. The FDA requires that any patient getting the gene transduced cell needs to be followed for 15 years. And that's exactly for this reason, because there are a lot of things we still don't know. And we can always mitigate, we can always manage. And so being vigilant about side effects, looking for certain things is important. It does not impact in any way our practice of utilizing this. And we can discuss further later on as the questions come about. So there are 4 important takeaways from this presentation. It's important to consider patient for CAR T cells, especially because we need to collect the cells. And the better quality of cells we collect, better the outcome. That's clear data. So start the process of identifying patient for potential CAR T cell, at least one line before they're ready for it. Especially you can tailor the last line of treatment, not to impact the T cell quality and T cell fitness. So earlier selection is better. Number 2, we have to keep in mind certain drugs need to be avoided because it impacts the type of cells we collect. Dexamethasone, bendamustine, melphalan, Cytoxan. So we want to be cognizant that we need to keep the T cell, again, fitness in a good shape. And there is much more emerging data about pheresis product, CAR T product, and the eventual outcome. Bridging therapy is important. As the patient comes in early, depending upon how much disease burden is, as Dr. Patel said, unlike the studies, this is where we have freedom to decrease the tumor burden so that there are less side effects and toxicities. And finally, the last point is that be familiar with infection management. In my mind, CAR T cell, and we'll go for bispecific as well, the issues are not CRS, issues are not neurotoxicity. We know how to handle it. but the longer-term management of infection and mainly prevention, because we can prevent it, is a critical component to having a successful CAR T-cell treatment, maintaining good quality of life. And so there are recommendations for this kind of management, and I wouldn't go through each of them. I think it's quite intuitive in many ways. You perform this in regards to treatment for many malignancies, induction for AML, post-autologous transplant, etc. But managing hypogammaglobulinemia is a very important component. And the reason is that the CAR T cells that we give targets myeloma cell, but also targets normal plasma cells. And so you would have hypogammaglobulinemia, really putting patients at risk for infections of various types. And this is where we routinely provide IVIG support on a monthly basis, especially if their IgG is less than 400. Some people use 500 limit. Either could be fine. We need PCP prophylaxis, especially if the counts are lower. Bactrim is the usual agent. And we need viral prophylaxis to prevent herpes-related issues, even if patient has previously received vaccination for that, because I think these are minimum required elements to keep patients safe. COVID-19, I think that's an ongoing issue. I think even though COVID has become a less of a life-threatening issue, it's an ongoing problem. Managing patients, CAR T patients for either first prevention and next treatment of COVID is of great importance because they're at a great risk, and it depends on various institutional policies. And maybe at the end, I will ask my panelists to see if they have any special word of wisdom for COVID management. The other things are not so common. CMV is not routinely followed, but if patient has prolonged cytopenia or other CMV activation symptoms or syndromes, then we can follow them. And same thing goes for PCP. So the last question for my part of the session is, because COVID is so common, any word of wisdom, Dr. Lee, on managing, preventing, treating COVID in these patient populations?
Yeah, I think COVID-19 is still relevant to our immunosuppressed patient population, so it's very important to be aggressive with hopefully prevention and mitigation. And so even though vaccine responses are blunted in patients who are immunosuppressed, it's still important to get vaccinated and up with the updated vaccines, because still some response is better than no response. And I think you do that pre and also consider revaccination post-CAR T as well.
Any additional comments?
No, agreed. And look for it. If someone has runny nose, etc., I test just to make sure if I know they have it, and then if I have availability of treatments.
I'll highlight one scenario to emphasize how important COVID situation is. We have at our institution, and our patients are not in excess risk of getting COVID. I would preface my answer with that. We have 6 patients who became COVID positive between getting their lymphodepletion and getting their CAR T-cell infusion. It's only 4 to 5 days time. We do check COVID before they get their lymphodepletion. They're negative. 4 days later, they get admitted and get their CAR T-cell. We checked before that, and they were positive just between the time. And then the issue comes, how do you manage them? So there are algorithms developed because we have identified quite a few patients. But to emphasize the point, there is a significant need to keep in mind COVID. As Dr. Patel said, be cognizant if there's coughing, sniffing, etc. Look for it, because we can very effectively treat and manage this patient without any complication. So I think this is for the first part of our presentation. We need to know that the manufacturing process requires 4 to 8 weeks, just to re-emphasize, and we are all dependent on slots. And so we will have time when we can select a patient for CAR T and can immediately go. Currently, that is still not the case. I think everyone is expanding their capability, so we have to keep that in mind. And the last word is that there are a lot of plans for improvement. Yes, the title of this one is Raising the BCMA Standard. I think our title for next time would be something even more fancier, because some of these newer methods to improve the outcomes with CAR T cells are going to be instituted. It includes using dual antigen. It includes doing different antigen, different transduction method. Also improving the type of T cell, whether we select CD4, CD8, or central memory cells for infusion. We can increase the expression of the target. And finally, as you are going to see in a minute, we can do it at an earlier time point when patients are in a better shape to get the better benefit. It's my pleasure to invite Dr. Karina Patel to take it from here.
Perfect. Well, thank you all for coming so early. This is amazing to see the entire room filled. And Dr. Munshi, with that great intro and initial studies of CAR T, my COI is I think everybody should get CAR T, even our 80 and 90-year-olds, as long as we can get them through it. So I'm really excited that hopefully very, very soon we'll be able to actually give it much earlier. And I think, we'll come back to this case in a second, but really the patients right now in fifth line, we know that with each line of therapy, our myeloma, there's less and less myeloma patients that get there, either because of our myeloma or complications. We have patients that drop out, they die. So a lot of our patients can't even get access to the CAR T in that fifth line because they can't get to that line. So we can talk about logistics and things like that are improving hopefully in the future as well, but this is really, really exciting. So coming back to Michael, 72-year-old, relapsed refractory myeloma, PS1, had RBD induction, then had transplant with len maintenance, but progressed after 2.5 years. So a little bit early progression, right? We say 2 years is high risk, but functionally 2.5 years is not really what we like to see as a optimal transplant len maintenance, consolidation maintenance. So he has early progression. Now he's len refractory. He was on len. Even though it's a low dose, we call that refractory. So he's functionally high risk. So if you had availability for early CAR T now, knowing the data that we're about to present, would you actually use CAR T as an option here?
I can take it first. So I think what is important for early treatment and even later treatment is to get MRD negativity. I think in newly diagnosed setting, you heard a lot about MRD negativity, and it's critically important to get a better outcome. Same thing applies to relapse patient, whether it's first, second, or third line. And currently, if you put everything in the perspective, which treatment gives us the best MRD negativity? And I don't think there is any doubt, especially this panel, because of course we are a little biased in favor of CAR T, but that gives us the highest. So I would definitely try to utilize it as early as I'm allowed to utilize. Of course, there are data pending, and some of the data is already there for this particular patient. I think there is good enough data that I would consider it early if I'm having access to.
Yeah, and
actually, if we ask the patient, the short answer is, I want CAR T cells.
To have that break, yeah. Hans, anything different?
Yeah, I completely agree. And I think just the ability to do it earlier will allow for optimal bridging and optimal cytoreduction. And it's less of a complicated scenario where, if there's some delay in getting the cells back or whatnot, that's okay, because patients actually will be able to have disease control, hopefully for a period of time on their second line therapy. And so there's a lot more flexibility in administering the CAR T when you do it earlier.
So on that note, the bridging, any particular thoughts for this patient, what you would use? Because you have so many options. RVD, what would you use for bridging in second line?
Yeah, so I would use a CD38 based regimen since the patient hasn't been CD38 exposed. And, if the patient is progressing very rapidly, short duration of remission on len maintenance, I'd consider a daratumumab proteasome inhibitor based regimen such as daratumumab carfilzomib dexamethasone or daravelcade dex. But even DPD could be an option because, again, you need just control for a few months before the patient gets CAR T.
Yeah. Anything different that you guys think?
So I totally agree.
Okay, perfect. So coming to the studies, right? So we had a couple of studies that read out this summer and ASCO last year. So CARTITUDE-4 is looking at cilta-cel versus PVD or DPD in patients who were lines 1 to 3 prior lines, so second to fourth line of treatment. So one of the earliest studies we have in CAR T. Patients did not have to have CD38 exposure, so that was a little different. So these are earlier line, and they had to be refractory to lenalidomide. So really important to look at these different, patient populations because they are different amongst all the different trials. And hopefully one day we'll be able to convince FDA to be able to say, it should be refractory or exposed rather than lines of therapy. As we change therapy so fast in myeloma, our patients are very different in early lines of therapy now. So again, refractory to len, no prior treatment with BCMA therapies, and couldn't have monoclonal antibody treatment within at least 21 days. So again, a large study looking at PVD versus DPD or cilta-cel in second line. And really, they're looking for progression-free survival and then secondary outcomes for depth of response and quality of life. So this is one of the best curves we've ever had for myeloma. Again, median PFS not reached in the cilta-cel group and 11.8 months in the standard of care group. The majority of patients did get DPD. I think it was like 85% of patients. But PVD was an option for those patients who were DARA exposed or DARA refractory. So again, they looked at week 8 where they had some drop off for both sides before and when they did the intention to treat, but a hazard ratio of 0.26 is pretty impressive for any therapy. And then looking at the forest plots. So again, in high risk and refractory myeloma, we talked about this, still really, really important. It does help patients who are high risk. Again, most of our therapies don't improve compared to standard risk, but this comes pretty close in my opinion. So even if patients had multiple different reasons, 1Q or the classical high risk 414, 1416, 17P, they still did well. Standard risk does, almost just as well. So interesting to see that here for response. And then refractoriness. Again, our patients are very refractory, but this patient got RVD, but now we use quadruplet. So most of our patients are getting these things early line. So still worked really, really well for our patients that are multiply refractory to IMiD, CD38s, and PIs. And then coming to what we were talking about earlier with bridging, why I harp on, yes, if I can get better bridging for my patients, they not just toxicity-wise, but low tumor burden measured by soluble BCMA in our patients is actually associated with optimal response and better safety. So here's that data. For both CARTITUDE, we have some data as well as ide-cel. But when you have less myeloma, you tend to have less inflammation with the CRS, endotheliitis, that we see with ICANS, even if it's subclinical, and even less infection sometimes because of that. So again, patients do better when there's less myeloma there. It's similar to what we talk about with transplant, why we try to go in the best response to transplant for consolidation. The immune therapy likes less disease. And then quality of life. So there's multiple different quality of life studies that have been done, but really compared to the standard of care arms, our patients, when they come to us, you can see the data here in different functional scale symptoms, but they come and tell us, they're like, oh my gosh, I'm not on therapy anymore. This is the first time I've not been on therapy for all this time. And when they do relapse, 1, 2, 3 years later, they actually say, do you have another CAR T I can go on? Because they just feel so much better when they're not coming in and on therapy with even the fatigue, et cetera, that they had before. So usually the symptoms are in that first 3 months, right, when they're getting the LD chemo and the CAR T and looking for CRS. But usually after that, that's where their quality of life really improves. And then again, we talked about other studies that have been done. So CARTITUDE-2 had multiple different cohorts, and this is looking at cohort A and B. And cohort A is again patients who had 1 to 3 prior lines, and then cohort B is those patients who relapsed early after 1 line of treatment. And again, both had great response rates, no CAR T related safety signals, like that neurotoxicity that we had seen in CARTITUDE-1. And again, this was the program where they started giving better bridging so that we can see if that helped the neurotox. And it did. It went from 9% delayed neurotoxicity in CARTITUDE-1 to 0.5% in the rest of their studies when you give better bridging. So then coming to the other CAR T that's also been done earlier now, so KarMMa-3, this was also in relapsed refractory myeloma. Here, this is 1 line later. So these patients had 2 to 4 prior regimens, so lines 3 to 5 now. And these patients did have to have daratumumab at least exposure, and majority were actually refractory as well. And everyone was refractory to the last line of treatment. And again, this was a 2-to-1 randomization compared to CARTITUDE-4 was 1-to-1. But here you got either ide-cel versus you had 5 options to pick from. So you picked based on what the person just had last or what they were refractory to. Again, this was 1 line later. So it's harder to just pick 1 or 2 because everyone does something different in that second, third line. So it kind of tells us how myeloma physicians think when we're treating and what options we have based on where that patient is and what they've had before. So again, even 1 line later, these patients were pretty refractory. 95% of them were refractory to DARA here. So we know that DARA refractoriness usually tells us patients don't do as well. But again, so you see the standard of care arm was 4.4 months. You saw in CARTITUDE-4, it was 11.4 months. So all the patients, just that 1 line, did much worse here. But 13.3 months for ide-cel. So again, a huge difference in terms of standard of care of what we have versus what CAR-T can do. And so again, we have our final PFS outcomes, and you'll see some overall survival data at the presentation that they're doing later this week. But again, significantly longer PFS with ide-cel. PD or death risk was reduced by 51%, so pretty impressive for our patients. And again, single ide-cel infusion versus continuous therapy, so hazard ratio 0.49. And so what about safety? So we talked a little bit about, we fourth, fifth line, yes, risk-benefit ratio is there. We want to do CAR-T, but what about earlier lines? Do you think the safety is still, equivalent, or is the benefit still worth the risk? And again, for both ide-cel that I have here, hematologic, those types of things we can really take care of. Infections, we don't see much grade 3, 4, but they do happen, so we really have to watch out for those. But really CRS and neurotoxicity, as Dr. Modi said earlier, for myeloma, we don't really worry about for the most part. If our patients are going in with at least stable disease and not exploding disease, they tend to do well with that. But it's really the cytopenias and the infections that we monitor very closely. And same thing with CARTITUDE-4. We do see cytopenias. We do see some CAR-T associated. The neurotoxicity. So, there are some patients that get some movement or cognitive. Again, it was 0.6% compared to the 9% that was on CARTITUDE-1. So bridging really matters. But there are some other things that we look out for, like facial palsy. So 10% of our patients can have that. It's reversible, but things that we have to kind of monitor and then treat if they happen. Okay, so coming back to our patient, again, had RVD induction, 72 years old, was, in first line with transplant len maintenance and functionally relapsed early. So if there were other high-risk features, would it provide a rationale for even earlier use of CAR-T, or would you even potentially treat this patient just because they're functionally high risk? Dr. Munshi, I'll ask you first.
Yeah, so I think this is a very important and also frequently encountered issue where patient has a truly high-risk disease, is biallelic 17p, or P53 deletion, etc. And we know they have a shorter outcome. And this is where, again, coming back to the same theme of getting MRD, true MRD negativity with 10 to minus 6 sensitivity or more, is critically important, because that's probably the only way out for this patient. And they constitute almost 20% of the patient population, so it's not a small number. But this is a setting where I would certainly consider, and that's what we're all hoping, we'll have access to CAR-T in that setting, to take it as early as we can. As you know, there are studies currently looking at post-transplant. If patients do not get the MRD negativity, or in some cases CR, they can get access to CAR-T cell in a study with exactly the same rationale that you can do transplant, get the best response, but if they don't get the best response that we are seeking, I would go and use CAR-T. So certainly, and that's what we hope we have access to.
No, I'm definitely in agreement. I think the near future is about getting CAR-T cell earlier, whether high risk or standard risk, actually, because although we're not bringing maybe high risk to become standard risk, but still they are doing better with the immune therapies in general.
Yeah.
Yeah, and I just want to echo Nikhil's point is, achieving sustained MRD negativity in high-risk multiple myeloma is absolutely critical for the durability of response. And so that whatever therapy gets you there, do that therapy.
Yeah, and I just, two things. We have patients that were on the earlier line trials, right, that were high risk, and they are 3-4 years out now with no myeloma. And I can't tell you that I would have been able to do that with any of the other therapies we have. So one of our actually junior faculty has a poster on our high-risk patients, and just the people who are diagnosed early, they can't get to fifth line. They can't even get to these because their disease is just so bad. So getting the high-risk patients early is really imperative, because that's the only way they're going to have access and potentially a change in outcome that's durable over years, because we know patients get treated after, their disease is different and sometimes even easier to treat than it was before. And I think Dr. Moti's point about standard risk, these are the patients we might actually cure, right? So there's about 16% of patients that are 6 years out from that original Legend study that are still in remission. So again, if we want to raise that bar, that's going to start with our standard risk patients. But again, it's that risk-benefit discussion we have with every patient when they're coming in.
So if I sort of reverse the thing and ask a question. So in high-risk patient, post-transplant, we always give maintenance. here, if you're going to do CAR T cells, and we talk about one and done, do you think there is a role, or is there a need for a role of maintenance post-CAR T cell? It's a controversial question because we are lacking true data. Right. But it would be good to give our own opinion
Agreed.
of what we should do.
And I think it comes back to the sustained MRD, that yes, even in maintenance, there are patients that we do triple maintenance for, but if they're 2 years out and still MRD negative and doing well, I might drop it to one drug. And 4 years out, I might drop it if they're having side effects, et cetera, versus pushing them through. So I agree with you. I think we have to get that MRD, but sustained. So likely for these patients with some of the novel therapies we have, we'll combine them to really get them and get everybody into that sustained.
Even post-CAR T cell.
But eventually stop. So I still want to stop for them too, if we can. But I agree. These are the patients that relapse early.
I think the beauty about CAR T cells today is a single shot. And this is why everybody loves it, especially the patient. However, we need to acknowledge, and there are ongoing trials, actually, CARTITUDE-6, for instance, randomizing CAR T cell to autotransplant, is using maintenance. So the question, I'm not against maintenance, but maybe we need to figure out a sort of a short duration of maintenance, because if we go back to the continuous duration treatment, we would lose a little bit of the beauty of CAR T cell.
And I think in the absence of data, probably just to pick and choose certain scenarios. So if a patient, for instance, had, 1 year of response after transplant, realized with bulky extramedullary disease, that's going to be very, very difficult to control long-term. That's a patient maybe you want to keep on therapy a little bit longer.
So that's why I think we're not pinning ourselves down to what maintenance. I think that would be a question. But especially in high-risk patient where we know there is a good reasonable chance, even late stage and early stage, I think some sort of consideration for a fixed duration may be in the offing.
Right. And just to reassure the colleagues, actually, there is a large outside clinical trial, large experience from China in many centers using IMiDs, for instance, after CAR T cell to stimulate and activate it.
Okay, so then talking about other novel ways that we can hopefully, kill more myeloma cells, get MRD negative, and hopefully get more cures in longer PFS. What about targeting multiple targets? So now we have so many different targets, but this is a study that was presented last year, updated at ASCO, and I think again soon, but targeting BCMA and CD19. So this idea that maybe CD19 is on early myeloma cells or stem cells. There's been studies that, have shown both sides, but I think the responses for these high-risk patients that got this BCMA CD19 dual CAR T was pretty impressive. So this is a novel fast T CAR T platform, 22 to 36-hour manufacturing. That's the other impressive part about this. We really need things that make us get our CAR Ts faster based on all the things we just talked about, getting patients through bridging. And again, just pretty amazing deep and durable remissions that they've seen. I think it was like 95 or 100% response rate. So here, this was RSS 2 or 3 stage. They had to have either high risk, they had some kind of high risk feature, but really got this in first line and newly diagnosed, and 100% MRD negativity as well. So again, going earlier helps, and maybe targeting more than one target for especially our higher risk patients. There's also other manufacturing processes that are being evaluated to make manufacturing faster. So Dercaptogene is one of those. They use a T-charge manufacturing process to make BCMA-directed CAR T within 2 days. Again, pretty amazing. Again, it relies on you giving the T cells at a low dose, but then they actually expand within the body, so in vivo, so that then they can go kill. So again, access is so big, and this could really change access. And again, response rates are phenomenal for multiple doses. The current standard of care in early relapse, we still do use CD38 base triplets, especially if patients haven't had it earlier. But I think we do now have data, and hopefully we'll have the approvals in the near future for BCMA CAR T in at least some patients in this line, including patients who are LEN refractory. I think especially for high-risk patients that they can't even get to fifth line, and it does change outcomes for so many of our patients. It's really, really important to get them this therapy. And we're really excited about the newer CAR Ts to, instead of 4 to 8 weeks for us to, wait, hopefully we can do it in 2 to 7 days. We still have to have clearance and make sure the cells are good, et cetera, but I think that could help a lot for access. And then just coming back to HealthTree, I've actually done a couple of conferences for them recently where they record a lot of our talks. And just last week, I have patients that come in. I actually tell them, they have this coach program. They have all these amazing things for you for support, because I only have 15 minutes with them in clinic. I actually pulled up one of my talks on CAR T and had them watch it. And it actually answers so many more questions than I could give them in that time. So again, great resources for some of these new therapies that we have specifically for patients on there. So with that, Dr. Moti.
Thank you, Krina. Good morning, everybody, and thank you all for being here in such an early morning session. It is such a pleasure to be part of this panel of esteemed colleagues under the leadership of Dr. Munshi, who has done a lot to advance this field of multiple myeloma. And actually, we're talking today about how to raise the bar in patients with a median of 6 lines or 7 lines of therapy. But maybe historical reminders to some of you, because in 1997, ASH was held here in San Diego 26 years ago. And the biggest highlight was melphalan high dose and auto-transplant first line. And we thought that was a revolution. And you can see the future goes very quickly, actually. So here my task for the next few minutes or so is to advocate, I would say, for bispecific antibodies, which are actually the other form of immune therapy which has become very, very popular. And in order to support my case, I'd like to share with you a real-life case, and I believe many of you have seen similar cases. This is a relatively young lady, 67-year-old, with relapse refractory multiple myeloma, performance status of 1 at presentation of a standard risk myeloma. I would say she received standard of care, quadruplet induction, DARA VRD, high-dose melphalan, lenalidomide maintenance. Unfortunately, she progressed, and then she was re-challenged with Dara-Pomdex, similar to the Apollo trial. Unfortunately, she was only able to achieve PR and 7 months of response. Then she underwent a treatment with a doublet KD as part of a clinical trial, carfilzomib-dex. Again, PR. So really a great responder. Duration of response 5 months. And then, for some reason, I must confess I ignore, isatuximab was added to KD with the hope that this would improve the situation. But unfortunately, it didn't last long, and she had a very aggressive relapse. And in addition, during the workup, there were some, I would say, some additional bad prognostic markers. So here, I'd like maybe to ask my colleagues about the best choice of treatment for such a patient who has received anti-CD38 several times, IMiDs, proteasome inhibitors, first generation, second generation, so triple class refractory, I would say. So what would be your choice, Nikhil, CAR T or bispecific?
I think it's a very deeper question. Part of the answer ends up being whatever is available, except if CAR T is available, which is where there is a bottleneck, BCMA is off the shelf and we can utilize it. Personally, I would consider CAR T cell, if available, as the first option. And the answer would be why, or the question would be why. There are multiple reasons. So number one is that if you look at the responses, CAR T provides, cilta-cel provides 98% response rate. It's certainly about 95%. So much more effective. And if you look at bispecific, in the best scenario, the response rates are 60 to 70%. So there's high response rate. MRD negativity, CAR T cell goes above 50. The other one does not. So that's another criteria. And the third one, CAR T is one and done. with whatever maintenance we do or not do. On the other hand, bispecific needs to be continued for a longer period, and we'll see what that means or not. But because of all this reason, I would personally feel preference for CAR-T if available. If not, bispecific provides very good response as well. And the second question would end up being, because both are to be utilized hopefully at some point, and the question would be, how do we sequence multiple BCMA targeting agent? And I guess we can keep that discussion, or we can go with that question as well. How do you sequence if we are both available, both accessible?
Yeah, and I completely agree with you. Again, I've told you all my conflict. I think everyone should get CAR-T first. But I think in this patient, right, so the logistics come in, and because that relapse is so aggressive, I always think, am I going to get this patient to cells? And if I can't get that patient to cells, I can't let them die without at least getting a BCMA therapy, because 60% is still better than anything else we have. So it's really hard sometimes to say, is someone going to make it through or not? But I think we're learning that when we get these patients, our goal is to get them into a remission and get to a response, because then we have more options. So for a patient like this, I would actually pick a bispecific to get their disease burden down. And then the question of sequencing comes up. So we have to deal with that. We know that bispecifics, your T cells over time are going to get exhausted. And there have been some manufacturing failures. If we give bispecifics for a long time and then try to make CAR-T right after, we don't have all the answers. How long do you wait? Is it 6 months? Do we give something in between to help those T cells? But in the end, for at least relapse refractory patients like this, I got to get them to some therapy that we have. And if they get a great response, we'll talk about a little bit more of what we do with bispecifics, that then hopefully later down the road we can get CAR-T. But in any other patient, if I can do CAR-T first, I try, and then we try to do for efficacy as well, not just for making cells, but we know the efficacy of CAR-T then. A bispecific tends to be much better. We don't see point mutations and all these other mechanisms of resistance as much in the CAR-T side of things as we do on the bispecific side. So, yes, we're always thinking about what are the options next line, and we don't want to, truncate any of those. But at the same time, I got to treat the patient that's in front of me.
I mean, I think this really highlights that it's great in 2023 that we have many options for myeloma. So one size doesn't fit all. And so we have bispecifics and CAR-T targeting BCMA that are highly effective in our patients. And I would also lean towards the bispecific in the sense the aggressive relapse. Of course, aggressive, what is aggressive, right? Is it biochemically aggressive? Is it exploding extramedullary disease? And I think really it just comes down to, can I get this patient to cells? And if the feeling is, no, I can't, then I think bispecific would be the best. If there is a possibility to get them to cells, then, and if there's a slot immediately available, insurance approval goes very smoothly, all these other things, end up working out well, then CAR-T could certainly be an option. So, but again, we have many options. One size doesn't fit all, which is great.
So I think one of the point would be that collecting the cells is an important consideration. At what time and what best setting that we would do that to take this patient to the best response between the options that we have.
So definitely these are actually, as you can see, there's no right or wrong answer. Obviously, there are pros and cons. And in this situation, my choice went to bispecific antibodies because of this so-called aggressive relapse. And unfortunately, while waiting for the, let's call it fast CAR in 1 or 2 days, we have to live with the word as it is, and bispecific antibodies are available immediately off the shelf. And obviously, there are some, I would say, considerations in terms of management. And we are actually very fortunate today, whether in North America or Europe and other places across the globe, to have 2 anti-BCMA directed bispecific antibodies being approved and widely used, namely teclistamab and elranatamab. I will speak later about talquetamab, which targets GPRC5D, and they are already part of the NCCN guidelines. And again, the key word here is about immune therapy. But in contrast to CAR T cells, where you're taking the autologous T cells, engineering them, educating them, I would say, to fight against a malignant plasma cell. Here we're doing a sort of an immune therapy in vivo, because with a bispecific antibody, on one hand, you can, I would say, bring the T cell through CD3 in contact with the malignant plasma cell with the tumor antigen BCMA, and this interaction would lead to T cell activation and would induce the cytotoxic cascade. And this is, I think, a fascinating mechanism of action, and it's true both for teclistamab, elranatamab, and all the other, I would say, bispecific antibodies. And teclistamab was the first to be approved based on this so-called MajesTEC-1 trial. And it has shown, and it has been mentioned by my colleagues, very nice 63% objective response rate. But I would kindly draw your attention to the 45% CR, more than CR rate, which I think would be of great value. And as expected, those patients treated earlier in the course of the disease actually are going to do better. And today, actually, when we look to the update of the MajesTEC-1 trial, actually, you have roughly 21, 22 months of duration of response for those responding. And this is very well reflected here when looking into the progression-free survival and overall survival, again highlighting the importance of achieving a very good complete response. And these patients who achieve CR are really going to do very well. But it's not only about the standard risk. Actually, when you look across the different groups, and of course, we know that the high-risk cytogenetics, extramedullary disease, high disease burden are always a matter of concern. And actually, like for CAR T cells, bispecific do work relatively well. Again, I think we are improving the outcome, the dismal outcome of these bad prognosis patients. Unfortunately, we're not yet reaching the same level as the standard risk. Like for CAR T cell, one, I would say, reasonable and good question to ask is, do we see the same results in the real life setting, the real world evidence? And the short answer is yes. And when we look to this presentation that will be given tomorrow, actually, in this annual meeting, and you guys probably participated into this real-world experience, you were brave enough because the patients who were treated in the real life actually had even more bad prognostic features. They were more advanced, which highlight, I think, that bispecific antibodies are a sort of, can be universally used, and we can discuss later whether there are really true contraindications to bispecific antibodies. And the real-world experience is apparently in line with what we've seen from clinical trials. And we do have a similar beautiful story with elranatamab, which is another BCMA-directed bispecific antibody. Please don't ask me what is the difference between teclistamab and elranatamab. All I know is that they both target BCMA, and it's always good to have two different options. But definitely, I think elranatamab was developed and approved thanks to also a very robust development program. It started with a phase 1 trial, the so-called Magnetism-1 trial, published almost like a couple of months ago in Nature Medicine by Dr. Baylis and colleagues. In this phase 1 trial, which really tackled highly advanced patients could already show a 64% of response. But there were also a very accurate, I would say, very precise documentation about the pharmacokinetics, but also how it ended up actually with this fixed dose, subcute dose of elranatamab of 76 milligram. This is based on the pharmacokinetics studies which are elegantly described in the paper, but also I think this phase 1 trial served as a basis to develop the strategies to mitigate the CRS. And the approval of elranatamab came from this MAGNETISM-3 study, single arm, similar to the Majestic 1, which was also published in August this year in Nature Medicine, and also showing a 61% overall response rate. So that reminds you actually the introductory slide of Dr. Munshi showing that now we have really increased the bar very high, above 60% in those patients. And similar to teclistamab, you are able to achieve CR in 1/3 of these patients who received a median of 6 lines of therapy. And when you look to the durability of response, and I think the community is now very familiar with this kind of diagram to show the responding patient, actually, again, all subgroup of patient can benefit, but we also see durable responses. And again, it's very intriguing with bispecific antibodies because in the real life, we have patients for whatever reason who had to stop and are in continuous CR for long periods. And this is again reflected here in the PFS and overall survival outcomes. When you look to those patients who achieved CR, for instance, we're really talking about like almost 90% of percentage of responses, around 15% the probability of a durable response. And similar to teclistamab, we will have an update, longer follow-up during this meeting. So I kindly invite you to attend the session on Sunday where we will show data on longer follow-up. And of course, you will be very happily surprised to see the impressive median PFS that is now achieved in the MAGNETISM-3 trial. It looks like that we're going to initiate a bispecific antibody against BCMA in this patient. And obviously, like for CAR T cells, I'd like to discuss with my colleagues about the safety and side effects that one needs to take into account. Nikhil.
So I think just focusing on bispecifics, the side effect profile in some ways would mimic, in general, what we see with CAR T cells. You see CRS happening in high number of patients, majority, small incidence of neurotoxicity. And as I said for CAR T cell, I think both are quite easily manageable. And that's why one of the topic for discussion later in this session is going to be how can we do this outpatient, because we can. I think my major concern with bispecific, to some extent also with CAR T cell, is the infection-related complication. Bispecific is currently, and that's another point for discussion, currently given indefinitely or for a long period of time. Suppresses plasma cell function, normal plasma cell function impacts other cellular component as well. And these patients are at a significant risk for infectious complication. And this is where I think instituting the preventative measure, because infections in large number of majority of patients we can prevent, should be considered upfront proactively so that we don't get into very complicated fungal infection and or other bacterial infection. So I think that would be my short answer, if you think it's a short answer, for the first bullet.
Rina, do you see there's the same concerns?
Agreed. I think lymphoma CAR T is the highest risk CR neurotoxicity, then myeloma CAR T, then myeloma bispecifics, right? I think it's always a grade lower, as Sagar Lonial always says too. And I agree that, yes, we have high risk of CRS, but they're all grade 1, usually fevers. For this patient, I would say, again, with so much disease burden, they likely are going to get that CRS, and probably I would admit this patient if they had a lot of disease going in, to watch them very closely. And again, IVIG infections are the biggest thing, and potentially why we're excited to see studies that have less often of the drugs and one day maybe even fixed duration, which could help the infection part, specifically with the BCMA bispecific.
Yeah, and I think that the timing of infections may be a little bit different in CAR T and bispecifics, meaning that in the acute phase of CAR T, sometimes you get these post-transplant prolonged cytopenias, neutropenia that lasts for 1 or 2 months, and those patients will be at high risk for infections, but then that will eventually hopefully improve. With bispecifics, at least the current paradigm of continuous dosing, you'll have not only depressed humoral immunity, so decreased immunoglobulin levels, but impaired T-cell mediated immunity as well. And so, infections are very, very important to monitor and manage with bispecifics. I can't state that enough. And so it's just important to be very aggressive. So aggressive with prophylaxis, PGP prophylaxis, IVIG, infection surveillance, vaccinations, things like that. So it's just very important to recognize that if we support patients properly in terms of infection prophylaxis, this can be significantly mitigated.
Wonderful. I think we are very well aligned, and actually these bispecific antibodies, it's a learning curve, and they are very popular. I mean, we are very enthusiastic about CAR T cells, but I can tell you, for a country like France, just by launching a compassionate use program in a year or so, more than 1,000 patients received teclistamab, hundreds received elranatamab, which highlight, obviously, the numbers for CAR T cells are not the same. And actually, probably we know very well how to manage, for instance, CRS, because both the development of teclistamab and elranatamab included this step-up dosing procedure, which actually allows really to mitigate or almost abrogate the risk of a significant or serious, severe CRS. And this is really very good news, including in those patients with high risk disease burden. And when it comes to the global overall safety experience with the bispecific antibodies, what we can glean from the literature, whether from MajesTEC-1 or MagnetisMM-3, actually we can have like 3 groups. Cytopenias, but we are in hematology. We are with patients who were heavily pretreated, including alkylating agents. CRS, nicely mitigated with a step-up dosing, but interestingly, and this is really the most important part, the issue of infections, which was highlighted by Dr. Munshi. And this is actually the same story, both in the teclistamab or elranatamab experience. But there are also some good news that beside the prophylactic measures, beside the supplementation with IV immunoglobulins, if you are able to switch to twice monthly, and this has been incorporated in the elranatamab protocols and used, but it has been recently, I think, approved for teclistamab. Actually, it is likely by really decreasing the frequency of infusion of bispecific antibodies in those responding patients, you will likely decrease the risk of opportunistic infections. And the pre-medication, and I like this diagram because it clearly shows, for instance, when it comes to CRS, actually at the beyond dose and the fourth dose, it always disappear, and it's not really a big matter of concern. But again, the issue is about preventing, anticipating, providing prophylaxis against the opportunistic infections, whether bacterial, viral, or fungal infections. Because at the end of the day, you are mobilizing the whole T-cell repertoire against a tumor antigen. So there would be some worries about surveillance against other, I would say, viruses. But again, I believe that we in hematology are quite familiar with the management of highly immunocompromised patients, and we know how to monitor frequently for viruses. We know how to do preemptive treatments, and we know how to do prophylaxis, but also immunoglobulin supplementation. And it's just about like reminding all of us, because myeloma patients are usually ambulatory patients, so we were not used to these infections. But I think with these guidance, I'm not saying they are the only guidelines, but this is just a very good example that we can help prevent all of these infections. So last but not least, I'd like to ask my colleagues whether they would have considered another option for this patient, because we know that we have another bispecific antibody being approved now against GPRC5D. Any thoughts on this, Nikhil?
I think BCMA, and maybe we'll have time, we can talk about BCMA loss, etc. Two possibilities: you go alternate BCMA targeting treatment, or use alternate target, which we have fortunately access to, at least from Bispecific at the moment, which is GPRC5D. And so if you have an access, I think that would be one of the consideration.
Yeah, agreed. I think if this is a patient I wanted to get to CAR T and I wanted to get them to CAR T soon, maybe I would do the GPRC5D bispecific just for the antigen piece, and then quickly get them to CAR T when I can, but no other reason.
Yeah, I agree. I would consider GPRC5D in this scenario.
Excellent. So a quick word about GPRC5D, another fantastic bispecific antibody. It's a different target. Talquetamab has been approved. Similar, the idea is a similar mechanism of action, and we already know that the response rate is above 70%, and in those patients with triple class refractory, similar to the BCMA-directed bispecifics, we can achieve more than 64-65% responses. The safety profile is slightly different, so you need to be aware of some side effects like dysgeusia, skin, nail side effects. So we still need to work on how to mitigate these side effects, which can alter the quality of life of the patient. But this is being now done, and I think the community, again, is more and more familiar with the way how to do it. And obviously, the future come very quickly. You can even envision a dual targeting for both BCMA and GPRC5D, and this has been already done in this so-called Redirect 1 trial. I'll be very quick, 96% of responses. So take-home message, I hope I have convinced you that today we have in hand not only the CAR T cells as a form of immune therapy, but also bispecific antibodies which are immediately available. The safety profile is well characterized, and we do have the, I would say, appropriate mitigation measures. Thank you very much for your attention.
All right. So it's really a pleasure and honor to be here at the session talking about raising the bar of BCMA. And in the last part of this session, I'll be focusing on some of the novel bispecific T-cell antibodies currently in clinical development. So we'll start with our case. And so this is a similar case that was discussed earlier. And in summary, Carolyn, 67-year-old woman, she had an ECOG of 1 at initial presentation with standard risk multiple myeloma, received frontline daratumumab VRD followed by autologous stem cell rescue and lenalidomide maintenance, second-line elotuzumab, pomalidomide, and dexamethasone, third-line carfilzomib and dexamethasone, and fourth-line isatuximab, carfilzomib, dexamethasone, with a fairly short duration response, the last line of therapy at 3 months. And now the patient has disease progression and has evidence of some clonal evolution with high-risk features with 1q21 amplification. And I think the question to ask my colleagues is I think the second bullet point is that, if, let's say, we are considering a bispecific T-cell antibody targeting BCMA in this scenario, we have actually a number of options. We have 2 commercially approved options. We have a couple that are in clinical development that may get approved later on. And so what would be the most important factors? There are similarities, but there are some nuances and differences between the antibodies that would make you consider one antibody versus another. And maybe I'll start in reverse order. Mohammed, what are some of your important factors that you would consider?
Well, obviously, I mentioned talquetamab, but also I think we have now cevostamab under development, and obviously these are good options.
Yeah, I think new targets are always great, but I think if comparing within the BCMA group, it's really hard, right? Efficacy, safety seem to be similar, but if you can find a way to decrease the toxicity, the infections, that's huge. I think less often the patients have to come in. We know that helps their quality of life. And then getting their disease down faster, especially for those patients with a lot of disease. So if there's one that gets to a better dose faster and can bring it down, again, little nuances, but I think those could make a difference.
All right. So in the next 20 minutes or so, I'll be talking primarily about 4 bispecific T-cell antibodies. So the first 3, linvoseltamab, ABV383, and alnuctamab, all target BCMA on the myeloma cell and CD3 on the T-cell receptor. Although you can see on the administration routes and summary of how they're given on the right column, there are some subtle differences between the 3 antibodies, which we'll get into a little bit more detail. And the 4th antibody, cevostamab, actually targets a new target, FCHR5, and then CD3 on the T-cell receptor. And this is an exciting approach to targeting, again, a different antigen besides BCMA and GPRC5D that has shown promise in clinical trials. So linvoseltamab is a bispecific T-cell antibody that targets BCMA on the myeloma cell and CD3 on the T-cell receptor. You see the structure of linvoseltamab as an IgG-based bispecific antibody seen on the left lower hand corner of the slide here. And linvoseltamab is being evaluated in a linker MM1 study. And in the part 2, or the phase 2 part of the linker MM1 study, it's 2 different doses of linvoseltamab, either 50 milligrams or 200 milligrams was being studied to optimize dose selection. And in the 200 milligram dose, which is the recommended dose, 117 patients were enrolled in the phase 2 parts of the study, heavily pretreated, median of 5 prior lines of therapy. About 3/4 of patients were triple class or refractory. And you can see on the right part of the screen, on the bar graph, the overall response rate was quite promising, 71%, majority being a very good partial response, or better, 59%. And there was a high rate of MRD negativity in patients who were evaluable for MRD testing. The responses also appeared to be durable and deepened with time. So this is a swimmer's plot of responding patients on the linker MM1 study in the 200 milligram cohort. And at a median follow-up of approximately 6 months or so, there was about 84% 6-month probability of duration response with linvoseltamab therapy. And in terms of the progression-free survival at the time of the current follow-up of 6 months, the median PFS had not been reached. In the 200 milligram cohorts, a 73% probability of 6-month progression-free survival, and more mature data from a later data cut will be presented at a poster session on Monday with the linker MM1 study. An important aspect of this study is the characterization of cytokine release syndrome. We know that cytokine release syndrome is an adverse event we see with CAR T therapy and bispecifics. And overall, the incidence of cytokine release syndrome was relatively low. So the overall incidence was 46%, with the majority being grade 1 severe. So the majority of these were just fevers and were managed fairly easily. And the majority of these events occurred during the step-up dosing period within the first 3 doses. And something also to highlight is the kinetics of CRS were also a little bit different as well. So with IV bispecifics, usually the median onset of CRS is more rapid, so within 24 hours, with the resolution within 24 hours. The subcutaneous bispecifics, the onset is approximately 48 hours, so with resolution, that takes a little bit longer. Again, this is just due to the pharmacokinetics of administration of IV versus subcutaneous therapies. And there is some quality of life data also being reported at this year's ASH meeting with linvoseltamab from the Linker MM1 study. And you can see here that in responding patients, the quality of life improved in terms of their physical functioning, decreased pain, decreased fatigue. I think this is not necessarily unique to linvoseltamab, but across the board with BCMA bispecifics, that once patients do respond, have their myeloma under control, these regimens don't involve dexamethasone, which often causes some of the most side effects with these regimens. And so patients actually have improved quality of life while on therapy, despite being on therapy continuously. And then finally, just wanted to highlight the dosing schedule linvoseltamab, which is slightly different than some of the other BCMA bispecifics. So step-up dosing is given 1 week apart. So initial dose of 5 milligrams and week 2, day 1 of 25 milligrams. And the target dose is given on week 1 or week 3, day 1 of 200 milligrams. And essentially, dosing is given weekly for the first 3 cycles, and then every other week for cycles 4 and 5. And then patients attaining a very good partial response or better can then de-escalate the dosing frequency in a response-adapted approach to every 4 weeks starting cycle 6 and onward. So pretty rapid de-escalation of the frequency of therapy. As I mentioned earlier, because of the rapid onset and resolution of CRS, this therapy actually required fairly minimal hospitalization for CRS monitoring. So only a 24-hour hospitalization within the first 2 step-up doses, which is also a very short period, perhaps relative to some of the other bispecifics currently in clinical development. And so based on the data from the Linker MM1 study, there is a randomized phase 3 study, the Linker MM3 study, that will compare linvoseltamab with standard of care elotuzumab, pomalidomide, and dexamethasone, and earlier relapse refractory multiple myeloma. So next I want to talk about onuctamab. So onuctamab is another BCMA bispecific T-cell antibody currently in clinical development. You can see here that the structure of onuctamab is a little bit different. So it's a 2+1 form. What does this mean? So essentially, one arm of the antibody binds to CD3 on the T-cell receptor, but there's actually 2 BCMA binding domains. So that's what the 2+1 refers to. And initially, onuctamab was studied as an intravenous administration form, but this is now changed to subcutaneous administration. And you can see here the dosing schedule is given with step-up dosing with smaller doses given on days 1 and 4, and then the target dose given by day 15, and weekly dosing for the first 3 cycles, every other week dosing for cycles 4 through 6, and eventually every 4-week dosing from cycle 7 and beyond. And updated data with onuctamab was presented at EHA last summer. And at the 30 milligram target dose, the overall response rates were quite encouraging, 65% overall response rate, majority of patients attaining a very good partial response or better. And the safety profile was also encouraging. So the right table here just summarizes the grade 3 or higher events, no grade 3 CRS, no grade 3 or higher ICANS. And the grade 3 rate of infections was fairly low, 10% actually, although this may be impacted by the shorter follow-up period. So with longer follow-up, perhaps the infection rate will increase as patients are on therapy. And there'll be additional updated data with onuctamab presented at ASH on Saturday in a poster session, basically showing updated response rates at the 30 milligram target dose at 69%. Again, majority of patients attaining a VGPR or better. And these are, again, heavily pretreated patients, median of 4 prior lines of therapy, about 63% that were triple-class refractory. So I think the question is, are there really any differences between these BCMA bispecific T-cell antibodies besides route of administration? step-up dosing schedule, the frequency of dosing. Indeed, there may actually be some other nuances of these bispecific antibodies that may be present. And, some of this may be due to the different epitopes that these antibodies actually bind to on BCMA. And this is actually a paper that was recently published out of Nizar Baylis's lab a few months ago. And really nice work that really looked at the mechanisms of resistance to BCMA bispecific antibodies. They looked at teclistamab and ransomab. So these are the two commercially approved BCMA bispecific antibodies. And basically what they found was that antigen escape, either through loss of BCMA through the biallelic deletion 16p, or due to missense non-truncating mutations, point mutations of BCMA that prevented the binding of teclistamab and ransomab to the extracellular domain of BCMA. And when they modeled these mutations, these point mutations in cell lines, they found that anutimab was actually still able to bind to the extracellular domain of BCMA. And, it's probably likely that the reverse have been true. Like, let's say you looked at mechanisms of resistance with anutimab, maybe there would be point mutations that teclistamab or ransomab could bind to. So I think the take-home message is that, perhaps we may need to do more in-depth profiling of BCMA in the future. This is of the future, where we're actually profiling tumor antigen, GPRC5D, BCMA, looking at detailed mechanism of resistance in BCMA. So not just about loss, presence, or absence of BCMA, but actual mutations. Maybe it'll be something like EGFR mutations in lung cancer, or BCR-ABL kinase mutations in CML. So we may need to get a little bit more detail on the nuances of these mechanisms of resistance in the future within myeloma. So lastly, I'll talk about ABBV-383, which is the third BCMA bispecific T-cell antibody that I wanted to discuss. And so the structure of ABBV-383 is also a little bit different as well. So it actually was designed with a low activating CD3 that at least preclinically seemed to decouple T-cell activation from CRS. And so this actually had important implications on the design of the study. So unlike all the other BCMA bispecifics, which there were step-up dosing incorporated with small initial dose, intermediate second dose, and the target third dose, actually ABBV-383 was designed with no step-up dosing. So the patients got the full dose of ABBV-383 initially. So this is nice, perhaps, for patients who are rapidly progressing, get the target dose right away. The other thing is that this drug is administered intravenously, but the dosing frequency is a little bit different. It's given every 3 weeks. So there's no initial weekly, then de-escalation from there on. And the responses are also encouraging as well. And so this initial data was published in the JCO probably about a year and a half ago. Updated data will be presented at the ASH meeting in a poster session with response rates, again, in the 60 to 65% range at the 40 milligram, 60 milligram dose, and the majority of patients attaining a VGPR or better. So going back to our clinical case, so we have a patient, same patient, Carolyn, 67-year-old woman with relapsed refractory multiple myeloma. And, after progression on fourth-line isatuximab, carfilzone, dexamethasone, patient did get a CAR T therapy. So the patient got a BCMA-directed CAR T therapy, but then had progression after 1 year. And so really the question is, what is the role of bispecifics in BCMA sequencing? So I think the first question I asked Nikhil is, would you consider a BCMA bispecific T-cell antibody in this scenario?
So I think if the question is, can we? The answer is yes, we can. Do we need to? Probably not, because we have an alternative target, which I may consider before going to BCMA again. So the entire question ends up being sequencing, because we have more than one option.
Yeah, I agree. I think the only patient would be if I think that they can't tolerate the toxicity, like if weight loss or taste is a big issue, then I would say for sure I would do a BCMA. But I agree, we have so many other options now that we don't have to worry about the antigen loss maybe right away.
I think it depends on the availability. If I have only BCMA targeted agent, I would definitely go for it. And there are data showing that it can work. Obviously, if I have access to another target, I would switch gears, although I may be able to come back to BCMA after. So if you allow to some washout period between two BCMA-directed therapies, purely empirical, but that's my thinking.
So great points. We do have some data now with both teclistamab and ransomab of the efficacy of these BCMA bispecific T-cell antibodies in patients previously exposed to BCMA therapy. So again, if potentially there's limited options for therapy where you're considering retreatment with BCMA down the road, potentially BCMA bispecific could be an option. This is Majestic 1, cohort C, which did allow prior BCMA exposure. And primarily these patients were exposed to antibody-drug conjugate, likely belantamab vedotin or BCMA CAR-T. And you can see the responses exceeded 50%. So you can actually attain a response in these patients with prior BCMA exposure. You can tell from the swimmer plot some of the responses were indeed durable. And the safety profile seemed to be pretty similar whether or not you're BCMA naive or BCMA exposed in this particular cohort. Similarly, there's been a pooled analysis of alranzumab in 4 of the different mechanism studies, and this was presented as an oral abstract at ASCO last year. And again, looking at approximately 87 patients with prior BCMA exposure, a little over, maybe about 2/3 of these were prior ADC exposure, and about 1/3 of them were prior CAR-T exposure. And interesting, you can see that the actual overall response rates numerically actually were higher with prior CAR-T exposure, and this may lend to some of the mechanisms of resistance between ADCs with continuous BCMA target exposure versus a one-and-done CAR-T. And also the median PFS and the median duration of response also seem to favor those who got BCMA CAR-T versus a BCMA ADC. So again, this probably lends to some of the mechanisms of resistance and antigen escape. But again, the take-home message is that if one needs to try BCMA bispecific, it can be done with some data to support, although now we have many options now. So you may not need to do that right away. So what are some of these other targets? So I mentioned earlier that there is a relatively newer antibody called cevostamab, although data has been presented regarding cevostamab for the last several congresses at ASH. And so cevostamab targets a tumor antigen called FCHR5. So FCHR5 is highly expressed on B cells and plasma cells. Something very interesting about FCHR5, it actually is located on 1q21. And there is some data actually that shows that there's increased FCHR5 expression on patients with gain or amplification 1q21, which is a high-risk marker, as we know, for multiple myeloma. And so cevostamab is administered intravenously, and it's administered with initial step-up dosing, but eventually the dosing frequency goes to every 3 weeks, which is quite nice for patients with the less frequent dosing. And it's actually in the initial trials of cevostamab also for fixed duration. So patients basically were treated for 17 3-week cycles for cevostamab, and some of the longer follow-up data shows that patients were able to maintain the responses even after discontinuing cevostamab after this time period. And what I want to highlight here is the overall response rates with cevostamab are quite good, almost 60% overall response rates. Many of these patients actually had prior BCMA exposure, so about 1/3 of patients had prior BCMA exposure. Again, basically, take-home message is that there are other tumor-associated antigens being targeted in myeloma, GPRC5D, FCHR5. I didn't actually mention furentumab, which is another GPRC5D by T-cell antibody being developed. And again, these antibodies are active in patients with prior BCMA exposure. So really, the take-home points is that we have 3 BCMA T-cell antibodies with fairly mature data with encouraging efficacy and safety data to date. There are many similarities between these BCMA T-cell antibodies, although there are some subtle differences, and they include routes of administration, IV versus sub-Q, the step-up dosing schedule, hospital requirements with step-up dosing, the dosing frequency and the de-escalation of the frequency of dosing as part of the study design, and depending on the IV or subcutaneous formulation, the kinetics of CRS onset and resolution, which could impact the hospitalization requirements for CRS monitoring. There is data that supports the use of BCMA bispecifics after progression on BCMA CAR-T with some clinical efficacy seen. And there's also novel targets in clinical development beyond BCMA. We heard about GPRC5D earlier, and also FCHR5 with cevostamab. And with that, I'll close and turn it back to Nikhil for the Q&A session.
Thank you very much. So we have 50 questions online. Of course, people from audience are welcome too. So I'm going to go through more like fast question, fast answer, one person answering one question, because there are a lot to cover and they're all very good questions. So I can start with Karina. What are your thoughts on outpatient CAR T-cell therapy?
Yeah, so we're doing it for cilta-cel already. The biggest thing is making sure patients can be nearby and get to the hospital if they are having CRS. So the second they get fevers, we bring them in. We are lucky that we have support to be able to do that, to get patients in the hospital when they need it. So most centers don't have that ability. So I think it really depends on your infrastructure. But I am excited that with, hopefully further and further support that people can build into their hospitals, more patients can do it outpatient.
So it can be done, but needs quite a work. Hans, how long do you continue IVIG?
So in the context of bispecifics, I use it continuously. I basically targeted an IgG number greater than 400. So basically give it prophylactically. So essentially as needed, we're checking it typically every month, and then usually ends up being monthly or every other month.
Okay. Mohammed, are T-cell lymphoma leukemia EBV driven, and do you follow for CMV in these patients?
Well, in our own experience, yes, we do follow, but this is not a universal recommendation. I think it is guided more by clinical symptoms. Obviously, if you have the luxury to be able to do PCR against CMV and EBV, then it would be great, but otherwise it's driven mainly by the clinical symptoms.
So there's a question about persistence of CAR T-cell. We have always said persistence is important because that's like a long-term maintenance. Do you think persistence is so critical? And what do we do to expand it, if that's true?
Yeah, I mean, I still think persistence matters for most of our patients, even though we don't see cells 3 to 6 months for most of the products that we have right now. So there's a lot of myeloma kill that happens in that first, and this is why we don't have the plateau, I think, that lymphoma has, right? The question is, we don't want them to last too long, because then we might see more of a T-cell signal that we don't want. So what's that perfect in between? And then is it going to be cell mods or IMiDs or other bispecifics that we use sort of as a consolidation that can help with that persistence?
I think one of the data that has come out is that if you look at cilta-cel data, it doesn't have a long persistence, but have an outstanding PFS. So I think we are still rethinking the role and need and implications of having persistence in this patient population. I think there is still a very important consideration about sequencing, whether we go CAR T or not. Is there any concern that responses post-CAR T with bispecifics are different than responses post-bispecific CAR T? So which one of the two you would prefer early if everything else being equal? There's some sense that post-CAR T cell bispecific works, but other way around may not be as significant.
Yeah, I think there's more emerging data, and actually this was data that was published recently from the U.S. Myeloma CAR T Consortium, which basically showed that responses after BCMA targeted therapy with CAR T are not as good. Whereas, as the data shown earlier, that you can potentially salvage patients with a bispecific after CAR T. So I think this lends to the mechanism of resistance, antigen escape, more potential for mutations and deletions to occur with continuous exposure to a BCMA bispecific. So I think, in general, the sequence, if everything was on the table, CAR T, then bispecific.
So then the question, Ahmad, is that, and there are two questions on that. Can we use bispecific as maintenance? And can we use bispecific as bridging therapy?
Yeah, so the question of the sequence today, all our answers are purely empirical, because I'm not aware of any controlled trial, because we say, and we've seen that bispecific after CAR T cells were better than CAR T cell after bispecific. But I can ask the question, if we collect the T cells before starting the bispecific and prepare, is it about resistance to a given signaling pathway, the BCMA, or is it about the exhaustion of the T cells? That's one point. Now, the second point, and we do have actually experience in France, in Germany, I have colleagues, etc., that actually bridging with bispecific to CAR T cells is incredibly nice. You can bring patient into VGPR, CR, even with one cycle, and then get them to CAR T cell. Obviously, the trials were not designed like this, but if you are able to do it, I believe that would be a very good idea.
So I think any comment, this is an important enough question that, and again, in US and probably elsewhere too, can you give both these treatments simultaneously, and more from insurance point of view or coverage point of view, can it be done?
I think it needs to be studied, yes. And I think Mohammed is a great point. We have a lot of retrospective data, but not really prospective data to look at these really in a systematic, detailed way. And so I think that needs to be studied.
Yeah, I think the toxicity is the biggest question too, right? Efficacy, if you're using the same antigen versus not, of course, are we down-regulating the antigen and you're not going to get a great kill as well? We don't know. But toxicity, do you need a washout between that bispecific and the CAR T before or after that hopefully won't have a neurotoxicity, target that we see down the road or anything like that? Again, we want these T cells to last, but how long do we really want them to last? So I think it's amazing, and I'm excited that the trials are actually going to look at this. But yeah, it's still the safety piece of it.
Then the question is there a role for CAR T or bispecific in CNS disease? So we can look at now subgroup of disease. We can start with the question on CNS disease.
So I can add, I think, Mood's in the audience. So one of our junior faculty actually is putting our CNS in the consortium together, and there are, not very many patients, but yeah, we've actually seen some great responses for patients that have CNS involvement. For CAR T, a lot harder to get them through, but again, I think bispecifics are another potentially great option. Again, toxicity we have to look at and make sure, but I wish we can include some of these patients on some of our trials as cohorts too.
I think one of the issues ends up being that all our regulatory studies exclude those patients, or data ends up being limited to start with till we are in the real world, where I think there is a good beginning of data that some of these may have efficacy. Related question, treating cranial nerve palsy complication observed in some of the CAR T cell therapies. Any comments on that? Especially if steroids are used, how would you use it? It's an open question in the sense it's treating CNS toxicity basically.
Yeah, go ahead.
No, you go.
I was just going to say that, if in those cases we treat typically with corticosteroids, and basically once the symptoms resolve, we want to taper steroids as quickly as possible. There has been some cases of refractory neurologic symptoms and maybe intensification of therapy, and just some data using even cyclophosphamide in those cases could be used. That'd be rare situations, but if needed, basically we treat with steroids as a mainstay of therapy.
So there are two related questions I might just answer. One is in regards to patient having plasma cell leukemia. Can CAR T cell be utilized? I think it's one of the scenario where it can be very effective. The key ends up being how do we take patients for CAR T when they have plasma cell leukemia, similar to the aggressive patient we discussed, to the need bridging with something effective. And the best measure to hold the disease while we prepare the CAR T cell is important. Collecting cell is not as easy, because if the percentage of circulating cells are high enough, producing CAR T cell is of a concern. So bringing the disease burden down, so a purer plasma cell preparation is phoresis is done, T cell preparation, and then take patient. Is one case report in leukemia where CAR T cells were prepared, but the CAR construct entered into a leukemia cell. Patients got that product, and that particular leukemia cell transfused with CAR was quite resistant to any treatment, and there was a permanent relapse. Doesn't happen in myeloma because we don't have much frequent circulating cells to that extent, and myeloma cell transduction ends up being of a different consideration. The second question is about, can we treat patients with renal failure, to what extent? The 1.8 was the case, but we have all treated patients with significant renal dysfunction. We have experience in using CAR T cell even in patients who are on dialysis. Requires spatial management, requires setup and experience in handling this. But either and both of the treatment, bispecific and CAR T, can be considered. I wouldn't say I would do it in everybody, but can be considered even if patient has an extreme or high degree of renal insufficiency in this patient. And the next question is about, can CAR-T be prepared and then frozen for use later when needed?
Well, in theory, we would love to have this, and this is being done, for instance, in some lymphoma constructs. As far as I know today, with the currently tested construct in myeloma, we don't have this option. This is probably about the future.
So I think we most of our products come frozen to us. So let's say somebody gets an infection like COVID, we can actually wait to give it until they recover, et cetera. The problem, I think, though, is where do we store them if it's years from now, right? The intention to delay is the hard part. It's more the storage and being able to do all that. But agree, that would be great if we could do it at diagnosis.
Yeah. So the relevant question is, can you give the same CAR-T cell again to the same patient? The product is made, half is given because of the dose, the other half is sitting in the freezer. 3 years later, patient relapses. Would you use the same material again in the patient?
I think it has been tested. Unfortunately, the efficacy didn't prove to be wow effect. So obviously, ideally, you would love to switch gears and use another construct, or at least go to a humanized construct. But again, I think we're lacking this experience. But I would say in some patients, why not?
Yeah.
But that's not ideal.
So in KarMMa-1, there were six responses out of 27 patients. So small number. In each of those 6 patients, because it was a dose escalation initial part, so each of the time the second dose, in patients who responded, the second dose was higher than the first. So maybe there is something to learn from that. Time will tell. One more question is, what currently approved novel therapies do you believe would make the most successful combination with bispecific antibodies? You can also include some of the newer up-and-coming immunomodulator and other drug as well.
Yeah, so I think that the combination of targeting 2 bispecific GPRC5D and BCMA through the redirect data was very exciting, particularly extramedullary disease. So really trying to focus on those really hard to treat patient populations. I think the extramedullary data with, for instance, mezigdomide is also very exciting as well. So maybe combining CELMoD with a bispecific could be an interesting strategy to then get better response with EM disease.
One of my bets for the future, for instance, let's call the elderly myeloma patient, is to be able to give frontline bispecific antibody plus an anti-CD38 plus maybe an IMiD, and have a sort of a fixed duration treatment that would allow them to have 7-8 years median PFS. We already know with Maya we have 5 years, so we may bring it to another 8 years. And if you are a patient who is 75, I think this is really the goal to achieve. Fixed duration treatment, and maybe sort it out with 1 or maximum 2 lines of treatment.
Yeah, being a CAR-T person, I think the GPRC5D CAR-T is coming down the road. I'm really excited about, especially putting it with the BCMA bispecific or a different target. I do think different antigens and different mechanisms are what's going to help hopefully cure more of our patients soon.
So I think that to summarize, I think we took quite a few questions. To summarize, I think it's an incredible time for us. Some of us doing this for a few decades. Some of us...
1 decade. That's it. I still...
But all of us have been doing CAR-T for a long time now, as long as it existed. It's an incredible time with responses that we have never seen before. And every year, there is tremendous progress that benefits the patient. So with that, I think we'll conclude this session. Thank you so much to my colleagues for being here, and thank you so much for being here.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MGG860. This activity is supported by independent medical education grants from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, Pfizer, and Regeneron Pharmaceuticals Incorporated.